Hi friends, today we're gonna learn about hypokalemia. It's defined as serum potassium levels less than 3.5 milliequivalents. Hypokalemia can be due to increased loss of potassium ions or decreased intake, or can be due to transcellular shift. See what are the causes for increased losses of potassium ions. It can be renal causes or extrarenal causes. 1. Renal tubular acidosis. Second one, drugs like loop or thiazide diuretics, amphotericin B, aminoglycosides, corticosteroids, etc. 3. Cystic fibrosis, ureterosigmoidostomy, mineralocorticoid excess like Cushing syndromes, hyperaldosteronism, congenital hypoplasia, and some high renin conditions like renin secreting tumors or renal artery stenosis. Extrarenal causes like diarrhea, vomiting, sweating, nasogastric suction, etc. Coming to causes of decreased intake or decreased store. Nutrition, anorexia nervosa, potassium poor parenteral nutrition, etc. Coming to causes of intracellular shift of potassium in cases like alkalosis, high insulin state, malignant hypothermia, etc. like conditions. Next, coming to hypokalemia clinical features. Usually non-specific symptoms predominantly are related to muscular or cardiac functions. In severe cases, due to muscle weakness, there can be neck flop, abdominal distension and ileus. For easy learning of clinical features of hypokalemia, use the mnemonic I am a sick vault. Here A stands for alkalosis, sick SIC, S stands for shallow respiration, I irritability, C confusion or a drowsy state. W for weakness, A for arrhythmia, L for lethargy, T for thready pulses. Here arrhythmia, the condition can be tachycardia, bradycardia or irregular rhythms also can be there. I, we can use it for decreased intestinal motility or ileus kind of things. So, main complication of hypokalemia has been cardiac arrhythmias and infarct. So coming to investigations. So along with general routine investigations, we need to do specifically serum potassium levels, urine analysis, TTKG, that is transtubular potassium gradient. This will help us to find out the etiology and treat accordingly. Transtubular potassium gradient. Transtubular potassium gradient. This is equal to urine potassium into serum osmolality divided by serum potassium levels in the urine osmolality. If transtubular potassium gradient is less than 4, we can say that kidney is not wasting excess of potassium. And if it's more than or equal to 4, there is significant renal loss present. Coming to treatment of hypokalemia, what we can do? Deficit should be corrected within 24 hours. First thing to do is identifying and stop ongoing loss of potassium. For this, potassium sparing diuretics and intravascular volume restoration with normal saline and correction of coexisting hypomagnesemia. Next is replacing the deficit. This we can do oral route if the patient is stable, and we can also do IV correction. Orally, we can give 2 to 4 milliequivalents per kg per day in 3 or 4 divided doses. Usually, the oral liquid preparation are bitter and diluted with juice or water. IV correction can be done when the patient is unable to take orally, or there is a severe hypokalemic state that is associated with arrhythmias and the potassium levels are less than or equal to 2.5 milliequivalents. Rapid correction can be done by 0.5 to 1 milliequivalents per kg over 1 hour, a maximum dose of 40 milliequivalents. Infusible potassium do not exceed 40 to 60 milliequivalents. Whatever it is, the main thing is to correct underlying etiology. Really very important to maintain a normal potassium levels, that is 3.5 to 5 milliequivalents. Thank you.